faculty to talk about active surveillance. It's one of the most important options emerging to combat the screening cancer, PSA screening issue. And I'm very happy that the first speaker, Laurence Klotz, well-known expert, will be talking and discussing with Marcus Grafen on active surveillance, pro and contra. And it's a second round because they discussed it only 2 years ago, so we can hear what we have learned for 2 years. Thanks. Laurence, please.
Okay, thank you, Maciej, and ladies and gentlemen. Thanks for the invitation to be here. It really was a wonderful meeting last year, 2 years ago, and again this time. And this was called round 2, so I thought, you know, how have things changed since 2010 when Marcus and I last put on the boxing gloves? And I think there's a number of areas that have at least moved forward. There's greater recognition and evidence of overtreatment. We've heard all about U.S. Preventive Service Task Force and wider acceptance of surveillance. There's better understanding of the nature of occult high-grade disease, the cases that we had missed with the original biopsies. New definition of clinically insignificant disease, which I'll go over. A better understanding of the flaws of PSA kinetics. Increased data that we've heard a lot about on multiparametric MRI that I think is really going to transform this area. Some new modeling studies. Longer follow-up of the surveillance cohorts, and some new randomized data on the role of 5-ARI. So this is a very active area, and there's new data in all of these domains. So I'm going to cover briefly why, who, how, and the future. So the first evidence that this has now gone from, I'd say, a provocative approach, not treating cancer, to something that's widely accepted. This was the NIH Consensus Development Conference on the role of active surveillance last December. So this was gathering together all the experts with an independent panel that came out with a report. The report is freely available from the NIH and really is a gorgeous summary of this whole field. And I think you could argue once you have an NIH State of the Science conference, you've arrived as an area. It's no longer questionable whether you should exist. So why? And we heard a lot about this earlier. The U.S. Preventive Service Task Force, PSA screening doesn't work. That's the front page of Canada's national newspaper. And the key issue was overdiagnosis and overtreatment associated with PSA screening. And just to cut to the chase, if there was a trivial intervention that was curative for prostate cancer, we wouldn't be talking about surveillance. But not to dwell on this, but the adverse quality of life effects of what we do to patients, there's no debate about this. This is one of the best overviews, a population-based summary by Martin Sand in New England Journal a couple of years ago. And sexual function, you know, 70 patients have a big problem with surgery. Incontinence, a total of about 25% have moderate to big problem, 44% a small problem, which not necessarily small in the grand scheme of things. So, you know, we have an impact on quality of life with our treatment. We don't yet have that trivial intervention. Microfocal prostate cancer is present in men at about the same frequency as their age as a percentage. 50% of men in their 50s, 65% of men in their 60s, and so on. We are finding this with trust-guided biopsy approach. So the first thing I want to talk about is what constitutes clinically insignificant prostate cancer, because that's what the proposal is, that we're treating this entity of clinically insignificant disease conservatively. The traditional definition, which is now 30 years old, dates back to publications by Tom Stamey in the pre-PSA era. It was based on 139 cystoprostatectomy specimens. They found incidental prostate cancer in 40%. He rated these by volume. The largest 8%, which was the lifetime risk of prostate cancer at that time in California, the largest 8% had a volume of 0.5 to 6 cc's. So 0.5 cc's of Gleason 6 or less prostate cancer was identified as the definition of clinically insignificant disease. Many people, including myself, felt this was far too stringent. And in fact, this has been modeled now by ERSPC. And the first point is, from ERSPC is, what percentage of patients are overdiagnosed with screening? And this estimate is around 50% if you compare the frequency of diagnosis in screened versus non-screened men. It's about twofold. So about 50% rate of diagnosis of cases that would never be discovered without screening. And the ERSPC group led by Dr. Walters, and you recognize the other names there, did a reanalysis of clinically insignificant disease using the STAMI approach, exactly the same. What's the threshold for patients who would never otherwise be diagnosed? 1.3 cc's is the figure that they came up with. Now, this is a hugely different phenomenon because 1.3 cc cancer has a diameter of 1 cc. We can find this with MRI. I'm sure we can find this in most of the prostate with histoscanning. If we don't have to worry about missing smaller lesions, like in the 0.5 cc range, then it really empowers us to take a much more conservative approach with these lesions that we might have worried about in the past. So that's the first point. Clinically insignificant actually covers a much broader group of patients than we have thought in the past. And this actually was shown by Peter Albertson earlier. The updated Albertson-type graphs of prostate cancer versus other-cause mortality. So this moderately differentiated in their analysis includes Gleason 6 and 7. But for moderately differentiated, which is probably worse than the kind of patient we're talking about, for T1C, you can see this is 25-year prostate cancer mortality untreated is in the range of 5 to 7% in men in their 70s and men in their 60s. So, that is the risk that we are talking about in terms of missing the boat or patients progressing to incurable disease during observation. Maybe 5 to 7% if we didn't treat any of them. One of the key questions in this area is Gleason pattern 3, or 3 plus 3 equals 6, really behave like a cancer? Does it have a metastatic potential? And one of the best papers to address this question was published about a year ago by a multi-center group led by Scott Egener, Scardino, Walsh, etc., 24,000 radical prostatectomies with pathologic confirmation in every one of them. So what happened to the patients who were Gleason 6 on radical prostatectomy? They had 12,000. The 20-year prostate cancer mortality, 0.2%. 2 in 1,000 died of prostate cancer. Now, for those of you who are biologically oriented, which I think most of you are, the outliers often provide the clues in nature to what's going on. So I asked the author, what's with the 0.2%? Because, those guys may really hold some clues. It turns out every one of them had elements of Gleason 4 pattern. So in fact, in 12,000 cases, none of them, for example, progressed to metastatic disease before they were treated. None of them failed locally after surgery and progressed and metastasized. In fact, the metastatic rate and the mortality rate was 0. So what does that tell us about the natural history of Gleason 6, true Gleason 6 prostate cancer? The reason every series in the literature of Gleason 6 shows mortality is because those patients were undergraded on their initial biopsy. So just to emphasize the difference between watchful waiting, which was the approach taken, as I understand, in Scandinavia and the UK in the 70s and 80s, and active surveillance. It's individualized. The patients have to have an option for radical therapy. The timing of treatment is to identify, preferably in the first few years, that they have worse disease and to treat them with curative intent. Who's a candidate? This comes from the NCCN guidelines, which is a US national expert opinion, and the distinction is made between low risk, D'Amico criteria, T1C, T2A, PSA less than 10, Gleason score 6 or less, and very low risk, which incorporates this plus the Epstein criteria, only 1 or 2 positive cores, regardless of the number of biopsies taken, and no more than 50% core involvement, PSA density less than 0.15. And those are all favorable risks. This is the NCCN guideline for very low and low risk. If you have less than a 20-year life expectancy, active surveillance preferred. So there's expert opinion in the US, a country that most people agree is overly interventionalist in terms of a lot of its management. And for patients who have a 10 to 20-year life expectancy, who are very low risk, or who have don't fulfill the Epstein criteria, it's the first of 3 options. So that, I would say, is the best consensus out there as to who is a candidate. Low risk, patients with 20-year life expectancy, very low risk, 10 to 20-year life expectancy, very low risk, pretty much everyone. We'll come back to the patients at the margin, that is younger patients with more than 20-year life expectancy or patients with significant amount of disease or elements of Gleason 4. So these are our results from about a year and a half ago. A third of patients are treated. This is based on, we now have about 900 patients in the cohort. This is based on 450. We did use PSA kinetics as a trigger for intervention. So 44% of the patients who were treated because of a PSA doubling time less than 3 years. About a quarter were treated because of a grade increase to 4+3. We didn't use the finding of a small amount of 4 as a threshold for intervention. Very few patients treated because of anxiety, around 10% of the ones who were treated. And the overall mortality, a third of the patients died at 10 years, and the prostate cancer mortality, we still have only 5 patients now out of close to 900 who have metastasized or died of prostate cancer. The longest doubling time in those 5 patients was 1.6 years. So doubling time seems to mean something. The calculated actuarial survival, 3% at 10 years. And this is a summary now. There's well over 3,000 patients in the collected, published prospective literature. The largest group is the Prius group. I'm not sure exactly how many patients they have, maybe 1,400 the last time I heard about it. They only have 1 death that they've reported. We have 5. The overall survival in the whole group is about 90%. The prostate cancer survival is 99.7%. A lot of these are too young as studies, too immature to really have collected the prostate cancer deaths that you'd expect. We know they come late. But there's at least 500 patients in these collected cohorts who've been followed for more than 10 years, 10 to 15 years. And there is no evidence so far of patients falling off a cliff when they reach the 15-year time point and suddenly all dying of prostate cancer. And here is the ratio between non-prostate cancer mortality and prostate cancer mortality over time. And this ratio is 19 to 1. Very reassuring to patients to hear that they have a 19 times greater chance dying of other causes. Now, just a brief comment about the Scandinavian trial of watchful waiting versus radical prostatectomy. We heard something about this earlier. This is the 3rd recent publication, New England Journal, May. No benefit in men over 65, and so on. It did reinforce the value of surgery in younger men. But here is, for the first time, they've published the outcome in patients with low-risk disease. And it's actually pretty impressive. Radical prostatectomy versus watchful waiting. There's a 50% reduction in mortality with surgery in the low-risk patients. So I looked at it and I thought, gee, maybe this surveillance really doesn't work. They showed a benefit. But actually, here is our mortality in the same time frame. So we have done much better with surveillance than they did by operating on the entire cohort of patients. And what does that mean? It means these are the so-called low-risk patients in the Scandinavian trial. Remember, it's a pre-screened group. So, and many of them had aspiration cytology. They are not anywhere near comparable with this mortality rate to a current screen-detected, stage migration, volume-reduced kind of cohort that Sunnybrook is being, that surveillance is being proposed for today. Now here is our PSA failure in the patients who were treated. The critics have jumped all over this. We have a 50% failure rate. Worse in the radiation arm. These patients were undertreated in terms of the dose. This is the same from Hopkins. They have a more restrictive eligibility criteria for surveillance, and they treat as soon as the patient has more than Epstein criteria. So naturally, they've done better in terms of the rate of biochemical failure in the treated patients. This is where there's room for improvement, and I think going forward, this is where MRI and biomarkers are going to play a major role. Having said that, a 50% failure in the 30% who are treated is only 15% of the cohort. The vast majority of those have responded either to salvage therapy and have certainly not died of prostate cancer. And here is the results of the REDEEM trial. The question is, will dutasteride in the off-treatment interval or finasteride improve the results in men on surveillance, stabilize the disease? So, of course, this trial was done long before the recent FDA decision that the 5-alpha-reductase inhibitors could increase the risk of high-grade cancer. But this study showed that if you take a surveillance cohort, it was about 300 patients, and randomized between dutasteride and placebo, there was about a 40% reduction in the risk of progression to higher grade cancer or bad PSA kinetics or the need for treatment. So it was a very positive study that demonstrated a benefit to 5-ARIs in patients on surveillance. No evidence of an increase in high grade cancer for what that's worth. So finally, the limitations of the current paradigm really relates to how we classify or misclassify the risk. And that relates to the missed high-grade cancer at diagnosis. Grade inflation is something I'm going to talk about in the next talk. And the triggers, have we got the right triggers in terms of grade, progression, PSA kinetics? So I think this field is actually becoming much more we can be much more confident that we're doing the right thing with more recent tools. The first thing that has been learned clearly over the last couple of years is that the missed significant cancers are usually anterior. And this is because we come at the prostate with a posterior approach. We know that most of the cancers are in the peripheral zone. That's what we target with the diagnostic biopsies. But about a third of patients will have more anterior cancers, particularly amongst the group of patients who, after a period of surveillance, are found to have higher grade disease. And one piece of evidence for this, and now there's quite a few papers that confirm this, is the Hopkins cohort, where they took patients on surveillance. A proportion of them had surgery. Of the ones who had a tumor volume above 1 centimeter, again, that threshold for clinically significant disease, 100% of them were anterior. So that's really a very strong piece of evidence that the problem that patients we have been missing have anterior cancers, and we heard about MRI, which I think is increasingly looking like the perfect partner in this setting, a negative predictive value of 95% according to Arnaud Villiers. So the way we are now doing this is the patient who has bad PSA kinetics or who has a little bit of grade progression goes on to an MRI, and if there is a large anterior cancer, they either get biopsied or treated. The other thing that I think is going to represent an advance in this area are these fusion devices that fuse the MR image with the ultrasound so you can really target the MR lesion very accurately. This is the kind of thing that I didn't realize there was going to be so much on MRI and imaging, so this is a little bit redundant, but you're obviously all aware that this can be done. And I think this will get us out of the box, the dilemma that we've been in the past, where you have a patient who has, say, a rapid PSA doubling time. Do you treat them? Do you not treat them? And this is just one example of a patient with minimal disease on surveillance. MRI shows this large lesion on diffusion-weighted imaging that was, in fact, a high-grade cancer. So if you tell someone they're on fire, they run for a fire extinguisher. We're making progress in terms of dealing with this public perception about the fear of cancer. There's been a lot of information about this over the last year or two, and I think we're moving to an era where this is a map of Africa from 1805, and the inside is a mystery. And we've thought of the prostate in these patients that way. That is, they have the biopsy shows microfocal prostate cancer, and people say, well, they might have something worse, so we have to treat them. In fact, I think now, particularly with the advent of MRI, I think there's a cow outside there somewhere. I'm done, Machi. With the advent of MRI, we can differentiate between these three different kinds of lesions and treat the patient more rationally. So I will stop there, I believe, and thank you very much.
Yeah, thank you, and we ask Marcus Graffen to